even in a place like Oregon, we're now at 41% Medicare Advantage, and it's good Medicare Advantage. The Medicare Advantage is high quality, guaranteed issue, community rating, that sort of thing. We still have well over half in traditional Medicare, and if you all could just tell us what you think ought to be done to deal with the fact, and I was glad that the chairman piped in that he's a low-cost state too, because a big chunk of us on this committee have what amounts to millions of seniors going to see, doctors, and there is a baked-in disadvantage under the reimbursement system for treating those people. And we thought it was going to get taken care of in the Affordable Care Act, and as of yesterday, a big group of providers, came in and said, we sure haven't seen much happen. So what would you tell us to advocate for to try to get the incentives that you correctly identify? Every one of the incentives and the paying for value that you have talked about, I'm for. It's just as of today, for a lot of us, those three up there at the top of the dais and Senator Cantwell and myself, it sure doesn't look very good because it just looks like we're getting another hit from what already is a system that discriminates against us. So start with you, Mark, and just tell us what you would do to make sure that all states can get the fruits of this new approach that rewards incentives and value.
Well, so long as Medicare fee-for-service is paying doctors on the basis of volume and intensity, which the current SGR program does, your physicians are not going to get ahead. And I'd say for Senator Roberts too, I've been to some of his critical access hospitals in Kansas, and the way that they want to deliver care, the way that they need to deliver care involves things like telehealth. It involves relying on nurse clinicians and other health providers instead of physicians. And those things, as you heard from him, are not covered under, even though we've got 10,000 codes, that they don't squarely fit within any of them. What will help is a move away from fee-for-service towards the payments that are more tied to what each patient really needs. And that's what I talked about in my testimony, what Bruce and others on the panel have referred to as different kinds of bundling, but focusing specifically on physician services and done, I think, not as a pilot. I think we're past that stage. I think building this into the Medicare program systematically. Maybe it could be done as an option that people could stay in the traditional fee-for-service system or opt into this more bundled approach to do. But I think we're at the stage now where there are enough good ideas out there. And you're seeing them in Oregon. Your state is trying to do this. The state has a real effort to move away from fee-for-service in its Medicaid and employee plans and the like. And that can be reinforced in Medicare and can be reinforced in every single specialty and primary care. The ideas are out there among the physician groups. I think it's up to this committee and leaders in Congress to give the physicians an opportunity to say how they would make those moves.
They're good ideas. Now. I'm just not sure they work for those three states and mine unless we take away this baked-in advantage.
But that's what you would do. You'd be taking some of the payments that are baked in, the fee-for-service volume and intensity, and shift them to something else. If what is working in Oregon is things like a primary care physician or a cardiologist spending more time working together to track what a patient's medication needs are, make sure they're on the latest evidence-based treatments, and spend time with them to prevent complications. The way to do that is to take what's currently in their fee-for-service payments that doesn't support that. The payments for the, maybe extra payments for the additional imaging procedures or lab tests or things like that, and convert some of those to a payment that would go to keeping the patient's needs met. And there are good measures for that. That's what Dr. Coburn was talking about. It's not easy to do in many cases, especially in small practices, and especially in practices that are treating vulnerable patients. But we don't have to make a wholesale change right now, overnight, to make this much easier for the doctors in your states. We can start getting
what the senator's getting at is a little concerned about the discrimination, if you will also be baked in.
Yeah.
And I think that's his concern. If you go to bundling, some of that's going to still be baked in for low-cost areas.
Let me throw in two ideas
You're
before
not
Bruce.
dealing with the disparity in different parts of the country. Bruce.
As a New Yorker, I probably ought to be the one to respond to this issue, and Senator Wyden and I have talked about it in the past. And Mark hit on one piece of this issue that's very critical if we're going to address these issues appropriately, and that is until we can adjust adequately in the data about utilization patterns and outcomes for the characteristics and the differences in the characteristics of the patients being served from one community to another, we can't fairly say that one place is more efficient than another. And in fact, if you contrast some of the 3-, 4-, and 5-year-old Dartmouth rankings of relative metropolitan areas on their relative efficiency with some of the more recent work done by MedPAC or by CMS, which has the appropriate data adjustments, you get very different rankings. And you find out that most of the difference in per capita Medicare expenditures from one region of the United States to the other is in fact associated with home care and durable medical equipment, not with differences in utilization patterns, because when you adjust for the characteristics of the patients, the differences are not as dramatic as has long been described. Now, I think we have two sets of problems here. One problem which is very real and which Senator Roberts talked about and Senator Coburn talked about is I am increasingly convinced that when it comes to physician payment and physician incentives, we probably just need to have a separate system for rural communities than we use for urban communities, because all of these new bundles and systems of care people are talking about require a degree of infrastructure and a critical mass that, as Senator Roberts said, is not realistic in smaller communities.
Accountable care. Critical access hospitals, for example, just reimbursed differently than...
Well, and I think we have a model, and we sort of gave up in the hospital sector. We said for hospitals of below a certain size, serving certain kinds of communities, the PPS system is never going to work equitably for them because the numbers just don't work. And so we created the critical access category. And I think there's no logical reason why we shouldn't apply the same logic to paying physicians in rural communities and figure out what it takes. The most important variable with a physician in a rural community is not how high quality is or how efficient he is, but whether he's there or not in the first place. So that's less of a problem on the island of Manhattan. So we shouldn't try to, again, develop a one-size-fits-all formula for these very different issues. On the other hand, I think we know less than we believe we do about the causes of variations in Medicare expenditures between the high-cost states and the low-cost states, as is evidenced by the fact, again, that the most recent data shows very different rankings of high cost and low cost than the Dartmouth Atlas has been showing. And the IOM is in the middle of a study which you commissioned to try to look at these issues and disentangle them. I think we need to get some better information about these issues, and it's in the process of being developed.
What's IOM?
Institute of Medicine. I won't pick on the New York